Good morning, everyone. Thank you so much for joining us in this room for a very interesting panel. And I have to say that it's very reassuring to see a room full, though, yes, it's one man with all women. So thank you so much for coming. But we do have a power-packed all-women panel. Uh, from the last ICFP where we struggled to, to manels, to, to this year seeing all women on panels, it is a great achievement. And I think we should all clap for ourselves. Thank you. And we've got more men in the rooms, which is great. So this is a panel on demedicalizing medical abortion and post-abortion contraception. And I think this is a very important topic as we are talking about WHO guidelines and the whole definition around what is safe, what is less safe, what is unsafe. We've gone far from the classical definition of safe and unsafe, but I do think the mantle is really upon us to clarify the definition of what is safe, what is less safe. How do we understand women's journeys and pathways as they choose medical abortion and support them in those processes? And what is the role that healthcare providers can play in making that journey comfortable, in making sure that in our need for overregulation, in our need for medicalizing care, we're not coming in the way of the journeys that women are taking, but are supporting and assisting them. And for this conversation today, I'm not going to get into the details of what's legal, what's not legal, what pathways women are taking, how many years, because, the fact that you're in this room means that you care deeply about comprehensive abortion care. I've got 4 very amazing panelists, but I will quickly introduce myself also. My name is Medha Gandhi. I work with the Bill and Melinda Gates Foundation. And I've been working in the space of sexual and reproductive decades, very across a spectrum of programs, looking at introducing family planning programs at large scale, at the community level, working at the policy level in the Ministry of Health, for introduction of the adolescent health program, then in between for a couple of years on directly working on comprehensive abortion care, and worked on the amendments to the abortion law in India, which is a very liberal and supportive law, which puts women sort of first. And to now working at the Bill and Melinda Gates Foundation, where I lead our policy advocacy efforts on a range of health issues with focus on family planning. So that's just about me. The way we will structure this panel is that our 4 panelists are sitting in the front so that they can see each other's presentations. And after about 12 minutes of presentations, we will break at the end and have them all on stage for you to ask questions. So please note down your questions by names, and we will come back to it at the end. I'd like to invite our first speaker for the day, Garima Matthias, who's from India. And she's a senior specialist programs and trainings at IPAS Development Foundation. And she leads large-scale implementing projects, enhancing post-abortion contraception and family planning, with over a decade and a half of experience in the space. Over to you, Garima, for your presentation on empowering users of medical abortion to improve uptake and continuation of modern contraception. Please.
Thank you for the introduction, Medha, and good morning once again, everyone. Thank you for joining us here. As my title says, it's about empowering users of medical abortion for their contraception needs. So just to lay the background, in India, as per an incident study conducted in 2015, 15.6 million abortions take place in India, out of which 73% are outside facility via medical abortion, that is self-use. The state, particularly where we are working, is Uttar Pradesh, one of the largest state in the India. I'll not go into the details of the demographics there, but would like to highlight that 3.2 million abortions happen in Uttar Pradesh, of which 83% are through self-use. Hence, this was something that we all picked up and the project was designed. So while designing the intervention, we thought that it would be very good to know what is the requirement, what does the community need, and what do we know. Basically, we know the data that 83% is happening, but where it is happening, how it is happening, from what is the source of procurement, etc. So we started with a formative research to understand the process, and then we conducted a human-centered design process to actually understand what do couple want, what do a woman want when they come, when they want their contraceptive needs to be fulfilled. This was followed by the feasibility checking of the design that was designed through the human-centered design process, and then with the final implementation. So I'll quickly take you through the journey that we have designed, the implementation plan that we designed, the program that we designed. So this is the program that we are implementing currently. Through our human-centered design and formative research, we found that chemists play a very major role in reaching to the clients, to the users who take self-use, who do self-use of abortion. So our beginning of the program is via chemists, the private medical shops, small medical shops. So we enrolled medical shops, chemists, pharmacies there. Then it was followed by having a helpline, which during the human-centered design, women said that they consider it as a credible source of information and they have access to phone. So they thought that helpline would be a private source, credible source for them. So we designed and we have a toll-free helpline where after the purchase of the kit, or the MA kit, couple can call or partner can call or woman herself can call and get to know about the post-abortion contraception information. And then this is followed by the facilitate part of it, that helpline via counseling and the discussion, facilitate the information about contraception and uptake of the contraception. But we didn't end there. We also thought that it is important that once a method is taken, it is to be continued, it is to be sustained. So we also have a provision of follow-up after the method is adopted. As per the method adopted, follow-up messages or calls are being made. And all this, of course, by the consent of the couple or the woman. So as I was mentioning, these are some of the key elements of the project. Our pharmacist toll-free number. This number is based locally. We have local counselors. We have 4 counselors and a very robust software, CRM as we call it, to enter the data, to take consent and to analyze the reports. We have 177 health facilities enrolled with us where the referrals can happen. This include both public and private. We also strengthen CHIs. Some of you may be aware that in India there is a whole cadre of ASHAs, accredited social health workers, who are based at village level and providing information, general health information, including family planning and reproductive health information to the community. So we strengthen them with the knowledge and proper counseling information. And then we also developed videos and messages that a couple can together look at. If they consent to receive it on WhatsApp or SMS, we send it to them. So once all this was in place, we had the design, we had the implements in place, elements in place. We did a quick feasibility checking of the program, of the solution that I shared earlier once it was ready. So we started a pilot with 250 chemists and based on the findings, we made a course correction in between. And I would also like to highlight here that during this period, India also had COVID lockdown when we were doing this from October 2020 to July 21. There was a lockdown and to our surprise also, though the facilities were not working, chemist shops were open, abortions were happening and women were calling us to know about the method and contraceptive services, to seek information, to get information. Based on the findings, we did minor tweaking in our solution. Our solution was more or less, I can say 95% was all appropriate. We had to tweak a few things to address to the need of young people, unmarried girls, and then we rolled it out with 1,200 chemists from July 2021. So here, moving forward, I'll be sharing some of the data that we have gathered and information and some of the findings till September 22, that is 2 months ago. Till then, we have received more than 9,000 calls from the couples. They have reached us. We also found that 70% of the calls are initiated by the partner, the male person. They are the ones who are going to take the medicine, they are buying the medicine, and they are the ones who are calling us first to the helpline. Uh, 74% of the calls are before taking the MA pill. We have to address, we acknowledge it, and we have to address some of the abortion related question before we go on to the contraception related information sharing and counseling, as that is the need that they want, that is the information that they want. So we answer to that and move ahead with the counseling on contraception, which is for the 92% of the callers that have called us during the first call. And then around 50% of them agreed for a follow-up conversation or follow-up interaction with the counselors at the helpline. So remaining 50%, we unfortunately, because of they didn't consent to us to give them call back, so we didn't call them. So this is the interesting profile of the callers that we have registered with us. 52% are from the urban or peri-urban area, 12% are unmarried, 42% are non-users of contraception before this pregnancy that they terminated. 28 is the average age of the callers who were calling us, and 14% was zero parity, low para couple that we catered to, and 22% had previously used MA has self-used MA. What questions do they ask us? They want to know about MA. They want to know about what to expect. If there is pain, how should I manage it? What are the side effects of continuously having a MA or during the process? When to start a contraception? And this is the most important question, and a large number of women ask us this question, that when to start the contraception? How can I start the contraception? There are queries, again, queries related to bleeding and how to use contraception. And also they share with us some of the myths that they are going through, they know from the community. So that is what they share with us. Now, through the helpline, we have been able to provide support to a lot of women, and this is some of the data there. We were able to provide in referral services to them. We were able to provide home counseling via the ASHAs, as I mentioned. We were able to provide a doctor consultation who required them, and we were able to also share WhatsApp messages and videos, as I mentioned earlier, as part of the component to these couples. Coming to the most interesting part of it, this is from an evaluation study being conducted by Population Council for the project. Average day of contraception adoption is 19 days within the first month. 50% of the respondents adopted any method, and 42% of them adopted a new method. So now what happened to the remaining 50% who didn't adopt any method? So as part of the study, it's multi-arm study, so they would be continuing it. But between the first and the 6 months, from these 50% who didn't adopt any method at the first month, 84% have been able, 50% again said that they adopted a modern method, and 84% any method. So to conclude, I can say that from this slide that our intervention is working. Some of our key learnings, and in case you want to use it for future projects, are it is very important that leaflet that has information about toll-free and all contraceptive is given to the client. So we started bundling it with the product that is there. Young buyers refuse to take leaflet. So we developed a small card for them just with a helpline number. The buyers who come to buy may also buy other products to maybe cover it or hide it, just such as the sanitary napkins or any other medicine. We also found, interestingly, that the adoption happened at 2 stages. First, an interim method, and second, a long-term method. So if a woman wants, most of them said that we want a long-term method, but right now I can't go anywhere to any facility, so I'll start with condom, or I'll start with OC pill. So the adoption is happening in 2 stages, and they are continuously in touch with us, and we provide them with required information. Thank you.
Thank you very much, Garima, for that very interesting presentation. And I think for me, what was an important takeaway was around what WHO says when we work on building the environment for a person to use any method that she chooses to. And a key step in that is availability and accessibility of information, right? And making sure that she has access to the right information the way she wants it. Like you said, they don't want a leaflet, so you customized it to a card, and they wanted a package, so, made those things happen. I think that's a very interesting innovation. And I think with that, we will make way for Karen to come forward with her presentation on innovation through telemedicine. Again, a way to support women in their journeys as they move forward. And quickly to introduce, Karen is the Executive Director of the Bixby Center for Population Health and Sustainability at the University of California, Berkeley, where her research focuses on improving access to family planning and safe abortion services within a very important aspect, rights-based framework. Over to you, Karen.
Thank you, and thank you all for being here on the last day, the last session. I know I'm going back to the United States feeling more energized and with new ideas to keep up the fight. It's been a really depressing couple of months we've had. And I think all of these sessions have really taught me that we need a bigger room for abortion at ICFP. And also you can see from my title that this is a collaborative work between many partners in Rwanda and many people, and I'm just the lucky one that got to be here to present. So I'm going to start with some background information that really informed our program design. In 2012, Rwanda expanded the legal grounds for safe abortion to include incest, rape, fetal impairment, and forced marriage, and then in 2018 to also include minors. However, access to services is still really limited to people outside of urban centers. This is due to stigma, bureaucratic barriers have inhibited full implementation of the law. 2014 evaluation of the I can't say that word, implementing the law showed that while it did a lot of work to increase safe access for women in Rwanda, also there was much work to be done to ensure that all eligible women did have access. So we had this going into thinking about, well, how can we improve access in areas that we're not seeing services? So we conducted a 12-month prospective SAFE study. And in this, we designed an intervention where we could bring first trimester medication abortion by using telemedicine. So we could bring it into the health centers and empower the mid-level providers while they could still be connected to doctors and get the authorization that was required as part of the legal framework in Rwanda. We conducted a SAFE study, so looking at safety, acceptability, feasibility, and effectiveness between October 2021 and September 2022 in 7 health centers in the Musanze district of Rwanda. And here I have an illustration of kind of what our program model looks like. So if you're a woman coming into a health center and you're interested in medication abortion, the nurse would complete all of your information in a service, in a record on online form. And then you would have a teleconsultation with a doctor who is connected remotely via telemedicine. So both the doctor and the nurse can be looking at the information at the same time. And then if the doctor approves the abortion, then the nurse would provide the mifepristone misoprostol combination pack. The mifepristone would be taken at the health center, and then the woman is sent home with the misoprostol. And then from there are 3 follow-up calls that the nurse will call the client. So the first one happens at 48 hours, and that was just to confirm that the woman has taken the misoprostol and has started to bleed. We actually didn't originally have that in our design, but during training, the providers really wanted that first check-in at 48 hours. and then another check-in at 7 days after, and that was just to confirm that there were no complications, how the side effects were going, answer any questions, and then at 14 days to assess the completion of the abortion. And so, as I already mentioned, our objectives were just to demonstrate that telemedicine can be effectively and safely provided at health centers by mid-level providers, and then to also assess the level of acceptability among the clients and also their satisfaction with the services. So we recruited anyone 15 years and older that presented at the health center interested in abortion services. They were eligible if it was a first trimester pregnancy. They were willing to be treated with medication and then gave consent both for participation in the study as well as for termination of pregnancy, which is part of the process in Rwanda. Our training, which kept getting delayed because of COVID, did happen in September 2021, and nurses participated in 3 weeks. We did include ultrasound training, which was also a requirement in Rwanda, though I do want to note that it is not a medical necessary component of first trimester abortion, but we did include ultrasound. And then besides training the providers that would be involved, we actually did a half-day training of the entire staff at the health center, including values clarification, just to help with some of the stigma piece that we had seen going in and just make sure everyone made a welcoming environment for people that were coming for services. And then also did a training of all the CHWs that were affiliated with each health center, because they were going then out into the community and would help with outreach and referrals. So data collection, we used RedCap tool. I'm not sure who's familiar. It's a secure web-based application where you can design and manage databases. And so when a client came in, the nurse would complete a bunch of forms on this online platform. And then the great part is at the same time, the doctor in a different place could be looking at all of the information. Also, I could be looking at information, the rest of our research team, just to check that all of our data was coming in without issues. So it's a really great tool for anyone trying to do like longitudinal clinic-based data collection. And then also the nurse could go back to that same form at each subsequent follow-up call. And so just keep adding more information. And then we also did client exit interviews 2 to 3 weeks after completion of the abortion. And that was conducted by our partner, Rwanda Health Initiative for Youth and Women. And they would just follow up on the phone and then entered all the data in Qualtrics. Okay, so now we can jump into some of the data. So here I'm just showing the sample characteristics. We had in our database, when I kind of started looking at it at the end of September, 228 clients. The majority were young, single, and had secondary education or more. In terms of the reproductive history, for most of them, this was their first pregnancy and no prior abortions, and 70% were not using contraception at the time of the consultation and when they got pregnant. So now I have some of the service delivery outcomes. So we had really high success rate. As you can see, we also had high adherence to the protocol. So 96% successfully completed treatment. There was still at the end, still 6 that were in progress. We had one that required referral to the hospital, and then just a couple where we were still doing a little bit of the data verification because there was a couple missing pieces just to know exactly what had happened. And then so there were 33 clients that were referred to the hospital when they arrived at the health center. 50% of those were because they needed second trimester services, which we were not providing. And then now here are some of the satisfaction results. And so we were, I'm going now, this is into our, the client exit interview. So this sample is 122 that were just randomly pulled from the larger database of 228. And so 97% of those clients reported being satisfied with the procedure. And the majority said that they did not have any challenges taking the misoprostol at home. The small proportion that did have challenges mentioned the bleeding was a problem, or finding privacy, or maybe the bleeding didn't come, so just like some more questions. Pretty much everyone reported having pain, obviously, but 17% said it was mild, 63% said moderate, and 20% said severe. And then in terms of the unanswered questions, when we dug a little bit deeper, a lot of those questions were about future fertility, maybe unknown consequences from the abortion that they weren't sure about, or when they could use family planning. So just kind of general things that hadn't been covered in, I guess, their counseling. The majority of clients did feel prepared for the medication abortion, but 16% said they did not feel prepared. And when we dug deeper into that, most of them weren't prepared for the pain level. And then you can see the other category is also somewhat large. And so there wasn't a ton of responses where they elaborated further on the other, but a couple suggested that they were unprepared for the feelings that they would have around the abortion experience. So they mentioned things such as like fear for the future, fear what might happen, and I didn't know I would have those feelings. So it felt like we have to unpack that a little bit more, but it was capturing in that other, more of a feelings piece that we didn't directly ask anything about. And then we were really excited to see such positive results for high quality of care. And so mostly everyone said that they felt respected, they have the privacy they needed, they were, during the counseling, they had got enough information, including any warning signs to look for, and 93% they would choose this method again, and 96% said that they would recommend it to a family member or friend. The majority of clients were counseled on family planning and told about the risks of getting pregnant after the abortion. Less than half of clients adopted a family planning method, and the most common was injectables. And among those that didn't adopt, they said they would either take a method later or were using natural family planning. A couple and the other, they talked about having fear of family planning after abortion or contraindications. And so our program implications, I mean, I think it's pretty obvious that using telemedicine has really brought services to areas that weren't getting services in Rwanda. So there's a lot of hope for this in the future, and we're actually now working on how we can change this into policy and new guidelines in Rwanda. One of our partners is the Rwanda Biomedical Center, which is kind of the research arm of the Ministry of Health. And anyone right now coming in and wanting to expand medication abortion services in Rwanda is actually using some form of this model to replicate in other districts. So we're hopefully going to have a lot more data coming in that then we can really use for policy change and amendments to the guidelines right now. I think the other interesting piece is when we were first going in, I mean, we did the training it was on Zoom because we weren't traveling at the time, and so we were using a lot of technology. We were using video conferencing, and then we're using this red cap to enter data, and phone calls to do this. They were doing ultrasound, and the technology was definitely the hardest part to teach, but also it really went smoothly. And so I think areas that maybe we don't think we can use technology as much, like there is an opportunity there, and I think we can try to use telemedicine and new technologies in places. And then the third point is I think there's also potential for telemedicine and just improving quality of sexual reproductive health in health centers in general. So the nurses that we've worked with really felt empowered by being able to be connected to a doctor, and if they had a tough case, even now we saw that they were using it for tough post-abortion cases, which weren't part of our study, but then they could reach out to a doctor and get some advice. And so we saw just referrals in general go down. So I think really connecting different providers through telemedicine or other technologies could be a way to improve all facets of sexual and reproductive health, especially in communities that are less connected to hospitals and doctors. So thank you.
Thank you very much, Karen, for that very insightful presentation. And like you mentioned, that the data, the sample was small, but the insights are very deep, and you're looking at working with the government of Rwanda on scaling it up. Would be also useful to understand how you're making it simpler as you move forward and sharing lessons beyond Rwanda to other countries too, to make sure that we're able to leverage technology. But we can come back to questions later. I'd now like to invite Lucia Bero Pizzarosa for her presentation on self-managed abortions via the internet and how service delivery data from women can really help this group understand the space. And she's a postdoctoral fellow at the O'Neill Institute for National and Global Health Law at the University of Georgetown. She holds a PhD in international law from the university, and I'm sorry, I can't pronounce that, so I will let you tell us about that, and a master's in journalism from the University of Oxford. That's an easy one. And an LLB from Uruguay. And she's consulted with IPAS, UNFPA, RSFU, Inroads, and others. So you'll please tell us a little more about your education too. Thank you.
I will definitely not bore you with details of legal education. Yeah, I know, but I have some notes here, so I'd like to kind of like keep it if that's okay. No, I think we're okay. How can I? Yeah, okay, great, we're there. Excellent. Is this good? Yeah? Does this work? Yeah, excellent. Okay, so thank you so much for the introduction. My name is Lucia. I work with Women Help Women, and I am also a postdoc at the O'Neill Institute for National and Global Health, and I work also in collaboration with the Mama Network, which I think most of you have met throughout this week, and I really hope you have because they do amazing work. So I am here representing a research team that we put together for this study that includes Tara Shoshet from the Genuity Health Project, Jennifer Bloom from the Genuity Health Project, Sara Larrea from the University of Pompeu Fabra, Kinga Jelinska from Women Help Women, and Irina Sagaidak and Rodriga Commandant that are the doctors that we collaborate with. So, and I also want to thank particularly the people that use the platform of Women Help Women, that we have the honor to accompany throughout their abortions. We are very, very grateful for their trust in our work. So I want to start, I am pressing the presentation. Excellent, great. So I just want to start with a little bit of a background because my presentation will be a little bit different from the ones that were done before because these are abortions that are happening outside of institutional health systems, right, with the support of a telehealth platform. So that they don't engage with medical doctors, right? They don't happen under the supervision of a medical doctor. They don't happen in a clinical setting. So we all know that with the pandemic, we have really catalyzed like simpler, less medicalized ways of delivering abortion care. And with that came the advent, for example, of telemedicine, right? But telemedicine was preceded by decades by organizations that have been doing telehealth work since like 1980s, right? We know that that since the 80s, Brazilian women have pioneered the use of medication abortion to terminate their pregnancies, and since then, a series of collectives and different forms of like feminist networks, hotlines, etc., have been appearing throughout the world in order to support people that need to self-manage their abortions outside of their clinical setting or want to self-manage their abortions outside of a clinical setting. So we have, of course, this has bolstered a very great interest on the topic of self-management, and particularly the obtention and use of medication drugs to terminate pregnancies. So we know that there's a series of organizations, as I mentioned before. Women Help Women is one of them. So we have partnered with here, yeah? Yeah, so this activism that has been very kind of like energetic, fierce, bold, etc., that have been working, developing a model of access to information to support to those who are self-managing their abortions, right? That there's an increasing form of activism that takes different shapes. has also generated the need to document this activism and document the experiences of those who have abortions under this model of care, right? We all know that for a long time we thought that safe, effective, dignified abortions were only happening in the clinical setting under supervision of a doctor. Well, now we know that that might not be the case, or at least the whole story. So we partner with Genuity Health Projects to conduct this research, and we did a retrospective study of data that went from 2016 to 2017, so 1 year of service, to basically, let me move to the next one, basically to analyze the goal of the study was to analyze women health women's service delivery statistics. This I'm gonna show here our quantitative study. We also did a qualitative study on this data. This data from 2016, 2017, when we have like an increase in the service that we were providing. And that we really wanted to see how were the experiences of people that self-manage their abortions using this telehealth medicine platform. Yeah? Okay. Excellent. So Women Help Women, I want to talk a little bit about the organization. So Women Help Women is an international non-profit organization, was established in 2014 to expand access to abortion worldwide using the internet and through on-the-ground partnerships with local activist groups. So Women Help Women forms part of this constellation of actors that are working both locally and transnationally to deliver abortion care, partnering with the institutional health system and sometimes working more autonomously. So the Women Help Women website is this platform that I was telling you about. It's a website that you can access. There's a series of very detailed information about medical abortion, and it also provides access to a group of skilled providers and counselors who will provide information and support and an opportunity to access medical abortion pills directly shipped to your home. So Women Help Women provides their information services to every country in the world through a team that speaks various languages. This particular study captured the work of people that work in 7 different languages and provides medications to over 100 countries in the world. So like people that may need the service can consult the form online that is reviewed by Women Help Women staff, and the pills are mailed if the individual qualifies for a medication abortion, right? So for that, we test eligibility, and this has to be like under 63 days. For this study, that is 9 weeks. We now know after the adoption of the 2022 WHO abortion care guidelines that we can safely use it until 12 weeks, right? So, and they also are assessed whether, in terms of the eligibility to, in terms of like whether they have any contraindications. So if we are not sure, if the counselors are not sure, counselors are trained, skilled people, but not necessarily medical doctors. If they are uncertain, we have a team of medical doctors that can provide a little bit of support in terms of like the eligibility, right? And then the additional evaluation is done if needed, and then the medication is shipped. So the users of this platform are asked to make a donation to cover the cost and help maintain the service, but those who cannot afford it can do it without making a donation. It can go for free. So 2 weeks after the person receives the package, and we assume that the pills have been taken, or we know that the pills have been taken because we keep in constant contact with the people that are self-managing their abortion, we send an evaluation survey. So that's how we also get a little bit of data and feedback on how we are doing our service, what are the areas that need to be improved, and whether the person has like safely self-managed their abortion, has it been effective, and what was their journey throughout this experience. At any point of the process, our helpline works 24/7. At any point of the process, the person can reach out to us, and an email will be sent immediately in their own language. Right? So we, like the work of Women Help Women is really founded on like the feminist ethos of meeting people where they are. So the data that I showed you before is from 1 year, so like August 1st, 2016 to July 31st, 2017. And let me see. Excellent. So, but I also wanted to mention, let me go back here, is that we have had quite an increase in the work that we do. Due to many, many reasons. We think it could be COVID, it could be the fact that many countries have it further restricted their abortion laws. For example, Poland. Poland is one of the countries in which we serve a lot of people. And of course we have, so like what this results in, like after the study was done, we had an increase on 74%, right? So that is like quite a lot. We had to expand the team. We had to work in different languages. So what I'm saying with this is like, maybe this data is not like fully representative. I think it's representative of the survey that we provide, but I mean, things have changed since 2016. So what did we find? So we learned that in the period that we analyzed, 3,307 individuals received medication abortion pills from Women Help Women. So this correspondence that happened to assess eligibility, but also to provide supportive services, was done in 7 languages. The median age was 27 years old, but the range of age was from 14 to 47. Most of them, I keep changing this, eh? Yeah. So most of them confirmed their pregnancy status with a urine pregnancy test, so 82% confirm using that method, while 30% use a serum pregnancy test and only 17% use an ultrasound. So we were able to find the final outcome information of those 3,107, the 295, right? And out of those, 2,508 reported taking the pills effectively. So all of these individuals, let me see if let me move one more. So yeah, almost all of the individuals, so 99.1%, confirmed that they were no longer pregnant. Approximately 1 in 5 people reported that the pain was intolerable. Other side effects were considered intolerable for like around 10 and 18%. And we measured for pain, chills, diarrhea, and other symptoms. So we learned with these that people are perfectly capable of determining whether they are pregnant or not and calculating the length of pregnancy. And most of them did so outside of any interaction with the institutional healthcare system. Only 20% actually interacted with the systems in order to determine whether or not they were pregnant. So the majority in our study successfully self-managed their abortion completely outside of the clinical setting. People using the service were supported to confirm the pregnancy, manage symptoms, and determine if and when to seek additional care if needed. The reported prevalence of serious adverse effects was very, very low, confirming the previous findings from other studies. And we also found that those who reported feeling intolerable pain, out of those, 80% was very, very satisfied with the self-managed abortion and was very, very satisfied with the service provided by the platform. So we also wanted to understand the emotions about the abortions, and the slide says women, because out of all of the people that we surveyed in this period of time, all of them self-identify as women in the form that we have available on the platform. However, we do not only serve women, we serve people of all genders, all identities that need and would like to self-manage their abortions. So following the abortion, as I said before, an evaluation is sent to people to fill in, and they share, and they are asked to share how they felt emotionally. So the majority of them reported feeling relieved or resolved, which confirms studies from other countries also, and is comparable to those results from abortions that happen also within the healthcare setting. Right? 2/3 felt comfortable, confident, strong, or happy, and 1/3 felt a little bit sad, guilty, and confused. So almost 9 in 10 reported being satisfied or very satisfied. Let me move to the next one. 9 in 10 reported being satisfied or very satisfied with the medical abortion, and 6.1% were dissatisfied or very dissatisfied. So the evaluation form that we send also includes questions about the system, the service itself, right? Like we want to understand whether we are providing good care and good support and good information to the people that contact us. So most people, let me see. Yeah, excellent. So most people, 90% reported that they were satisfied or very satisfied with the information provided. 5% said they were dissatisfied or very dissatisfied. So the support from Women Help Women was kind of like highly praised in this study, and nearly all of them, so 98% of the people that respond to the survey would recommend the website to a friend, and a similarly high proportion, 96%, would recommend medication abortion to a friend desiring to end the pregnancy. 2 minutes, okay. So, yeah. Let me go a bit quicker here. So, of course, there are limitations to the study. These are retrospective analysis of data. So there's a lot of data that was missing, evaluations that were not completely filled, etc. And we were not able to tailor questions or ask further questions. However, further studies that we have done since then that are prospective studies have allowed us to cover also these areas that we were not able to cover in this study. So what does this mean, right? So we heard from colleagues about very successful experiences with telemedicine. So what our study kind of like comes to show is that the success of the women's service delivery model, so individuals seeking abortion care from a wide variety of geographic locations with varying legal status of abortion also, were able to access the care that they needed using this platform. The vast majority had successful abortions, so abortion was effective, the medication is effective, and the quality of the service, the quality of the care is not affected by the fact that the services are provided telematically. So yeah, and I think this also builds on a lot of the literature on self-managed abortion, which is that it's been increasingly recognized as for the potential that it has to contribute not only to enabling safer abortion trajectories, but also to contributing to people's agency, autonomy, and decision-making in the reproductive field. There's, as I said before, there's high levels of satisfaction. I'm going to move quickly, and we can close to questions. But so it is the work of these organizations, like Women Help Women, the ones that have cemented the path towards policy change. In 2022, we have been doing the service of self-managed abortion since 2014, very successfully, as you can see. But in 2022, this model was recognized by WHO as an alternative model of care that should be embraced not only as a last resort, but as an option that should be available to everybody that would like to terminate their pregnancies. And then I just wanted to close saying that our study confirms what we I think experiential knowledge of activists already we had that accumulated throughout decades, but that we knew that people can people can safely and effectively end their abortions with community and with community support and without medical supervision. And I want to emphasize that it is this work at the margins of the law, that the ones that have advanced science, that have advanced the public policy that now rely on, and even the way in which we talk about abortion. Abortion can be a safe, affirming, dignified experience supported by community and supported by different systems of care, namely hotlines, namely activists, namely even the institutional healthcare system, right? But it can be a safe, affirming, and dignified experience. So I'll leave it there.
Thank you for that very wonderful presentation. And you referred enough number of times to the abortion care guidelines released earlier. But what for me was the key takeaway of the presentation was the fact that you went back to women and understood their satisfaction. And I think that was a very important factor to say that when women are supported in the settings where they are and are taking the journey the way they want to, that is really the key, whether it's for abortion care or any other type of service. And that, for me, was the key takeaway from your presentation. Thank you very much. That was lovely. And now we move over to Colombia. We've got Maria Mercedes, who's the executive director of Orientame Clinics in Colombia, and she's going to be talking about the telemedicine for abortion provision in Colombia experience. She's the executive director of the clinics in Colombia, and her work has focused on finding innovative ways to expand access to sexual and reproductive primary healthcare services, particularly contraception, abortion, and post-abortion services. Over to you, Maria.
Okay. Good afternoon, everyone. Thank you for being here. I want to begin by recognizing the work of many, many people that have come before me in this field, especially in Colombia, but in Latin America in general. My presentation is divided in three. I will tell you about Oriéntame, about our telehealth program, specifically about telemedicine, and we'll share with you the results we obtain when comparing in-person services with those provided by telemedicine. Oh, okay. So Oriéntame is an independent clinic founded in 1977 to provide post-abortion care. Oriéntame has been a pioneer in the region, in Latin America. One of our main objectives is to decrease access barriers to legal and safe abortion services. Therefore, we have always seen the importance of demedicalizing and simplifying abortion to ensure access, while demanding that the healthcare system recognizes abortion as any other health service. Currently, Oriéntame, that's so slow. Currently, Oriéntame has 11 clinics in 8 cities around the country and provides abortion services up to 24 weeks of gestational age. 77% of our services are medical abortions. We also provide contraceptive services and STI counseling and testing. We took an initial step towards the medicalization of abortion about 12 years ago when we decided to have a toll-free hotline. Women can call and receive rights-based information and oh, no, it's too fast. Okay, sorry about that. Women can call and receive rights-based information and a pre-counseling session as part of our services. We took the first part of the process out of the clinic. That first contact with women gives them the information required to access health services and arrive with a better understanding of what to expect of the process. So we have a telehealth program for abortion provision for up to 11 weeks of gestational age, composed by tele-expertise or professional-to-professional support and telemedicine, or professional-to-client support, using mifepristone and misoprostol. Through our telehealth program, we ensure the availability of trained human resources and access to supplies. Today, I will be focusing on telemedicine services or the provider-to-client service. Back in 2019, oh my goodness, I'm sorry about that. Back in 2019, before the COVID-19 pandemic, we were working on launching the provider-to-provider telehealth service. However, in March 2020, when the mayor of Bogotá and the president declared the mandatory lockdown, we shifted gears, adapted the infrastructure, and started providing services directly from medical doctors to women. So we started the telemedicine program at the beginning of COVID. The very first day of the lockdown, we sent our first kit to a woman who needed them, with very stringent mobility restrictions and with the previous law in place, meaning that in Colombia, people could legally have an abortion only in 3 situations: to preserve their life or health in case of fetal malformation incompatible with life, and when the pregnancy was due to violence. At that moment, the right to choose did not grant legal access to abortion. Mifepristone and misoprostol are registered in Colombia. They have been for a while. However, people must have a prescription to obtain these pills. The country regulation allows the provision of telemedicine or telehealth services. Okay. The first step is service promotion. Pregnant people become aware of the service through the web page and the promotion on social networks. They call Oriéntame's contact center and schedule an appointment. Then A nurse assistant calls them back to receive general information and verify pre-eligibility criteria for telemedicine care. That means having an internet connection, that's a requirement, gestational age less than 10 weeks of gestational age currently, and an absence of IUD in situ. Just the 10-week limit we have is because in Colombia things happen and mailing out packages can take longer than expected. So in order to prevent going further, we have that current limit. Then the medical appointment is scheduled and consent forms, patient's rights and duties, and payment instructions are sent by email for digital signature. The medical doctor carries out a video call, medical consultation. The consultation includes information on sexual and reproductive rights, options, and contraceptive counseling. The medical doctor determines the gestational age based on the last menstrual period and identifies contraindications for medical abortion and risk factors for ectopic pregnancy and excess bleeding. Afterward, the doctor proceeds with an explanation of the use of the medication. The way this consultation is carried out is an essential part of simplifying services. We do not request any additional tests or sonograms. Afterwards, if the patient is eligible, we send a medication kit. It's called ALAS or WINGS in English, and schedule a telephone follow-up with the nurse 2 weeks later. The kit contains instruction for medication use, mifepristone and misoprostol, pain medication, short-acting contraceptives of choice, contraceptive leaflets, urine pregnancy tests, and an order of ultrasound or BHGC order. Women can access this way. Women can access abortions through self-care interventions without clinical supervision in their homes. At the same time, they have the benefits of being in the healthcare system. For instance, their procedure is paid by the healthcare system, and they can have mifepristone and misoprostol directly delivered to them. We compared all the telemedicine medical abortions we provided from the 24th of March 2020 to the 30th of June 2022. There are more than 16,000 abortions we provided, only medical abortions. A total of 2,855 medical abortions, and we compared them with the in-person medical abortions that are 14,723. The effectiveness is exactly the same. 99% of telemedicine abortions were effective, meaning there was no need of having an MVA to complete the procedure. And 98% of in-person medical abortions were effective, meaning they didn't need, not even touching it. They didn't even need, further intervention. We then compared all the in-person abortions we had in that period, more than 26,000 abortions provided, with those in telemedicine. And surprisingly, there was no difference in any regard. We found no significant difference in terms of security perception. There was no significant difference in terms of actual adverse events. And women's overall rating of the modality of care was also very similar. However, the percentage of responses to satisfaction surveys from women in telemedicine was higher than in those responding about in-person services. Although the distribution of women by region is more varied in telemedicine services than in in-person services for obvious reasons, 30% of the services in telemedicine still happen in the country's capital. That means we need to emphasize services, we need to make services better known outside the capital, in rural areas, and in peri-urban and rural areas. However, in these areas, we have a strong barrier that is the digital gap. Regarding the age distribution, there is no significant difference, but that result is not, I mean, I think we have to make a better effort to reach younger people. It should be higher for the telemedicine, or we expect it for telemedicine to be higher among younger people. So we need to make a better effort in promoting services among younger people. Regarding post-abortion contraception uptake by modality, there is no significant difference either. However, the percentage of women who initiated a mother contraceptive method after a telemedicine abortion is 9% less than in person. That's also something we need to work on. On the 21st of February, the Constitutional Court in Colombia ruled to decriminalize, under any circumstance, abortion up to 24 weeks of gestational age. This was thanks to the Causa Justa movement. After this gestational age limit, the 3 exceptions of the previous ruling still apply. The Constitutional Court finally accepted that criminalizing abortion affects the right to women, the right to health, violates the freedom of conscience of women, girls, and persons with gestational capacity, disproportionately affects marginalized communities, and improperly uses the penal law. When it comes to self-managed abortion, this ruling removed the requirement that medical doctors certify the legal eligibility for abortions up to 24 weeks, contributing further to the medicalization of abortion provision. To conclude, telemedicine is highly effective to provide medical abortion. Women can effectively self-manage their abortions. They don't need support or supervision. There are no significant difference between in-person and self-managed abortion provided through telemedicine. Telemedicine supports access to safe and legal self-managed abortions with high-quality standards in early gestational ages. It was pushed forward during the pandemic, but is here to stay. However, it has limitations, and one very big one is the digital gap, especially in countries like Colombia. Telemedicine cannot be the only model of care if the objective is to provide comprehensive sexual and reproductive health services. And something that I didn't talk about, but I live daily, is that it imposes administrative challenges to institutions. The system and policymakers always have to catch up. They're always behind. Thank you.
That was a fabulous presentation, and I guess I will now ask our presenters to come on stage and take seats across. And for those of you who have questions, would request you to walk up to the mics and ask your questions. If you have a question to a specific speaker, then let us know, or you could just ask a general question. I think your presentations were so clear that there are no questions. Is that right? All right.
I'm Matana from Thailand. I'm health desk of Women Help Women. And thank you very much for the very excellent presentation. And I just feel very curious for myself that because Women Help Women provide information via the email. So we haven't chance to face the current. And I would like to know that how do you deal with the disabled group like LGBTQ, that's very sensitive. I myself have come across sometimes, and it's still difficult to improve the service to access. And so I would like to know that in the area like another country like India, Rwanda, and Cambodia, I'm so Colombia, sorry. What do you do with this group, and do you come across with this group? Thank you very much.
It's a great question.
Thank you.
Let's take 3 questions, so both of you, and then we'll open it up.
Yeah, thank you so much for the presentations. They were beautiful. One is about the implementation in Rwanda. Was this, were the providers attached to the facilities public facilities or private facilities, or both? In terms of post-abortion family planning uptake, is there still follow-up for those who did not take up? And was there any non-completion of abortion that needed surgical intervention at one point? Then I think for both, Orientame, is there, you said there was more uptake of post-abortion family planning in for those that took telemedicine instead of those that went physically, if I got it right. But what's the uptake? And yeah, just wanted to compare the uptake with the Rwanda intervention. Thank you.
Thank you so much for great presentations. I'm Kazuko from Japan, and now we are also fighting for the access to safe abortion in Japan. And one of the biggest problem we have is that abortion is like the biggest one of the biggest profits for the gynecologist, because it's cost like $1,000 or $2,000, and we always have to pay, and only the special trained doctors can do it. And we don't have a medical abortion yet. We only have surgery. So on the way, actually, one of the biggest opponents is, unfortunately, the medical doctors. And no matter how much we bring the papers from WHO, they say it doesn't care in Japan. So like, if you get any like resistance from the doctors, I would like to get some comments like how did you overcome or how you are fighting against. Thank you so much.
All 3 very great questions. Do you want to start with the question on the different communities and how to, so the question from Thailand, if you can respond to that, because you mentioned that in your presentation, and then
Yeah, excellent. So about the first question in caring for abortion with the queer community. So there hasn't been a lot of studies. I think IB's Reproductive Health has a study on how trans and non-binary people access abortion services and what are their particular needs. The WHO has developed their language and now speaks about women and also people with the capacity to gestate, or uses like interchangeably some of these categories throughout their new documents. But there hasn't been a lot of like work on this. At Women Help Women in particular, we started asking. I mean, we try for this information not to be too heavy, right? But we want to understand how people of different genders experience self-managed abortion. And we did a very small pilot study in Nigeria in collaboration with a collective that works with queer people. And we saw that the reasons why they would prefer to self-manage an abortion pretty much mirrored for like previous research. Like it is discreet, it is convenient, it is cheap. It allows them to go back to their normal activities in like much like faster pace than if they had to navigate the formal healthcare system. So, I mean, I don't think we can make like huge conclusions on this, but I think there's kind of initial steps taken to understand what are the experiences of these particular groups in accessing healthcare services. And the one thing that came out in our pilot in our pilot studies is that these marginalized identities have for the longest time been medicalized and been in hostile encounters with the formal healthcare system. So they are particularly kind of like worried about having to interact, forcibly having to interact with a system that is hostile to them when they could be doing this outside of the system, right? So that's what I can say on that.
I don't have anything to add to that question, but I can answer the question specific to Rwanda. So they were public health facilities. The private facilities in Rwanda are all religious-based. So yes, all public. And then the second question, I don't think I fully grasped. I think it was around the family planning and post-abortion family planning that we only had 50%. It's something that we have a program review coming up, and we need to understand a little bit better around the counseling and communication. What I sensed from looking at the data and talking to providers was that they were, instead of providing a method the day of the consultation when they sent the client home with the misoprostol, they were asking them to come back afterwards. And so I think that gap was, and they weren't coming back for a method was actually the biggest issue. And that we did not have any complications that resulted in surgical abortion. The one where the client was referred to the hospital was actually when we did a case review of it. The first abortion was successful, but then they ended up pregnant very shortly after, and that one was ectopic. And so then it felt like, but then we looked at the time. At first we thought it was the same pregnancy, but it wasn't. It was a different pregnancy. And then we're working closely with doctors. So the question from Japan about resistance from doctors, I think what we saw through the year of the implementation was in the beginning, everyone was very strict with the protocol, and then the telemedicine was happening, the consultation, and then things were getting lax where actually the researchers had to keep saying, like, we need to do the teleconsultation, and they felt so confident in the mid-level providers that when the video call was coming through, they're like, oh, it's okay, like, we know you can make the decision. They were just authorizing. It was actually us as the researchers saying, no, we have to stick to the protocol, like, we have to do it this way. So I think if you engage them in like systems where you really need to work with medical doctors from the beginning, and the design, the training, and then often kind of the evidence and what's happening starts to speak for itself, and then everyone really, I mean, hopefully our end goal with the guidelines is that we don't really need the telemedicine where we're getting authorization from medical doctors, that it actually could just be mid-level providers providing the care. Thank you.
So to answer the question about the contraception uptake, it was the other way around. In person, the abortion, the percentage of people who uptake a modern contraceptive is higher in in-person consultations than in telemedicine. And basically it's because the long-term acting method, the most popular long-term acting method is the IUD, the copper IUD. And that cannot be provided through telemedicine, right? It has to be, the person has to be referred to a healthcare center. That's why I say that this cannot be the only model to provide services, because if we want to provide a comprehensive array of services, we need to have in-person services and mid-level providers and so on and so forth. The uptake is high. It is 66% after a telemedicine consultation, compared to 75% after intake. It is a good uptake, but we see the trend, and we see the trend in medical abortion and in telemedicine. Those two combined pose a challenge for a contraception uptake. And regarding working with doctors, what we've seen is that mid-level providers, nurses, general practitioners, are the ones who provide access to services. OBGYNs, with all due respect, I'm a doctor, I'm an insider, OBGYNs are not so pro-access. And one of the things is that I don't know if they feel threatened. I'm not quite sure what the issue there is there, but the key is to work with mid-level providers. That's my take on this.
Just to add to the point and advice to the Japan, you asked question. So I think identifying champions within the sector would be something that can be done, because in India we have professional networks of the private providers and OBGYNs, and working with them, advocating with them, and finding champions there who can speak for the cause, who can speak for the successful procedure of MA. Could be of help. We recently had amendments made in our MTP Act, Medical Termination of Pregnancy Act, and these were some of the things that helped us advocacy and identifying the champions.
Can we take just one more question? Because I don't think we'll have more time than that. So let's take one more question and then a final comment from each one of you. Go ahead. Why don't you take the mic there? Do you have a question?
Actually, my name is Daniel from MediHelp Switzerland. We work very closely with Kinga Jelinska from Human Help Women, and we have maybe one proposal where self-administered abortion and actually menstrual regulation could be very much increased and made facilitated, especially for countries like Japan, but also many African countries where abortion is illegal or stigmatized. What we have done in Zambia with the leading professor of gynecology, we have done a study showing that using mifepristone alone and 50 milligram is enough. And we have documented the study, and it was published in the South African Journal of Gynecology. Mifepristone alone, within 3 weeks of missed period of 7 weeks of pregnancy, will bring back menstruation. It means that maybe we should think about a change of the protocol, making emergency contraception, which is also mifepristone, 10 or 50 milligram according to WHO. So let's say we have a super emergency contraception, which is 50 milligram of mifepristone, which can be a once monthly contraception as well. We are using that in Congo and sell a lot of it and give it for free to hospitals. So a once monthly contraception, an emergency, a super emergency contraception could be the one being in stock in Japan, and once women need it and they are afraid about a technical, complicated procedure, they will just take one single tablet, drink it with water, no difficult application under your tongue and checking, or maybe having cramping, and this will, in 96% of cases, I'm happy to share the study results with you, lead to a returning of menstruation within 3 or 4 days. So menstrual regulation, using only mifepristone rather than using the combination, being done by volunteers, being done by the network partners, and not being done by gynecologists who often want to do the expensive procedure, might be a solution for Japan, might be a solution for Africa, Rwanda, where the medicine is, and especially the combi pack, is not available. So think about that, maybe having stocks of mifepristone, low dose, 50 or 100 milligram, you can break it into
Thanks
two.
a lot for that intervention. And no, I agree with you that there is constantly need for newer innovation. And I do think we would all love to hear more from that. But I want to be mindful of the fact that, you know, we have our panelists on stage, and just before we end the final session of ICFP, you all have 30 seconds each to make your final interventions. Each one of you had fabulous presentations with a lot to take away. But yeah, 30 seconds each. Let's start from you.
So you're saying just a final thought?
Yeah.
No. Well, I mean, I think I've said everything. It's been really that I wanted to say. I mean, I wish more of our team could have been here, but thank you all for staying till the last session, and I think we keep pushing. I've learned so much from colleagues today, and even though we were working in a system where we still were requiring the legal framework is a bit more stringent, I think there's a lot of hope and excitement, and I'm going to bring home much more ideas to the United States, where we need all the help we can get right now. Thank you.
Yeah, I just want to close saying that I feel the concern of a colleague from Japan. Self-managed abortion is a topic that has for a long time been resisted in the medical community. Yesterday, in a panel in which scientists presented research on self-managed abortion and activists were there with experiential knowledge on self-managed abortion, somebody asked if our measurements were incorrect. And that was a medical doctor. So I want this to be a call to the medical community to embrace the evidence, the public health evidence, and the international human rights standards, to embrace the potential of medication abortion, self-managed, telemedicine, or in clinic. Whatever the person wants, whatever the person needs, put the pills and the information in people's hands.
Fabulous.
Echoing that thought, I think it's high time for us, with all due respect to everyone sitting here, doctors and professionals and managers, everyone here, it's high time for us to give the due autonomy that women in the community want. They deserve it, they have it, and let us pass it on to them. Let's use technology, let's decriminalize, simplify the procedure instead of complicating the things for the women. Thank you.
Something that we sometimes forget is that medical doctors we are here to guarantee rights. That's our main job. And the demedicalization and a person-centered approach through telemedicine can be the way to guarantee those rights.
Thank you so much. That was such an amazing panel, and I think we're going to all take that thought with us. I think I'd just like to close by saying women have chosen the pathways that they're taking. It's really for us to walk the path with them. So thank you so much for coming for this session. Hope to see you all in the closing. Thank you. Thank you.